quick revision. Sympathetic system originate from thoracolumbar area. It form a connection in the ganglion, which is near the spinal cord. So preganglionic fibers are small, postganglionic are long. In the ganglia, the neurotransmitter, like every ganglia, is acetylcholine, whereas the postganglionic fiber, they mainly secrete noradrenaline. So just like in parasympathetic system, as we discussed about acetylcholine, here we will discuss about noradrenaline. So noradrenaline is produced and stored here. Now, from where this noradrenaline comes, the answer is same. Noradrenaline is produced by this neuron because this is a neurotransmitter. But for noradrenaline formation, the raw material is taken from outside, which is tyrosine. So first step is tyrosine comes from outside. This is converted to dopa with the help of an enzyme called tyrosine hydroxylase. Tyrosine hydroxylase is the rate limiting enzyme in formation of noradrenaline. Now this dopa is converted to dopamine, and dopamine will enter and forms noradrenaline. This noradrenaline is stored in the vesicle. So whenever nerve impulse comes, noradrenaline is released in the synapse. Now this noradrenaline work on receptors and sympathetic action comes. We know sympathetic action is to stimulate the heart but relax most other parts of the body. Now we want to stop the action, and the major method of termination of action of noradrenaline is reuptake. It go back into the vesicle and the action stops. Just like in parasympathetic system, the main action of sympathetic system is due to presence of neurotransmitter, that means noradrenaline in the synapse. So if we increase or decrease the level of noradrenaline here, we can manipulate the sympathetic activity. And what are the options we have? The options are, we can inhibit the rate limiting enzyme, tyrosine hydroxylase. We can inhibit the entry of dopamine in the vesicle, and we can inhibit the release of noradrenaline. So three drugs we can use which decrease noradrenaline in the synapse. These are, the drug which inhibit tyrosine hydroxylase enzyme is me-tyrosine. Me-tyrosine. Again, from the name you can remember, me-tyrosine. The name says I am tyrosine. So the enzyme get confused to act at which place, because the drug is saying I am tyrosine. So in this confusion, the enzyme will stop working. So it is a competitive inhibitor of tyrosine hydroxylase. Now the drug which inhibits the entry of dopamine in the vesicle is reserpine. Reserpine, it inhibits the entry of dopamine in the vesicle. And third drug which inhibits the release of noradrenaline is guanethidine. So the three drugs, me-tyrosine, reserpine and guanethidine, they decrease noradrenaline in the synapse, so they decrease the sympathetic activity. Similarly, if we give a drug which inhibits the reuptake of noradrenaline, if noradrenaline do not go back, it will stay here, so that will produce more sympathetic action. And the drug which inhibits the reuptake, example of number 4 drug is cocaine. Cocaine is a reuptake inhibitor. So it will increase noradrenaline in the synapse, that will increase sympathetic activity. Now next thing we need to discuss about is the receptors, because noradrenaline will finally act on receptors. Now receptors of sympathetic system are of two main types. These are alpha receptors and beta receptors. Sympathetic receptors are alpha and beta. Alpha and beta. Now alpha receptors are further of two types, alpha 1 and alpha 2. And beta receptors are of three types, beta 1, beta 2 and beta 3. So we'll start the discussion from alpha 1 receptor. Alpha 1 receptor, although it is present all over the body, but you need to remember three main areas which will solve your all the concepts, and they are also helpful in solving the MCQs. And these three places are: 1. It is present in the blood vessels, where the main function is to cause vasoconstriction. Second, alpha 1 is present in the eye. The effect is to cause mydriasis. And third, alpha 1 is present in the prostatic urethra. Prostatic urethra. And we all know effect of sympathetic system on the urine outflow is to decrease the urine outflow. So alpha 1 receptor in the prostatic urethra is decreasing the urine outflow. And in which prostatic condition urine outflow is already less? It is BHP, benign hyperplasia of prostate. So what will you like to do on alpha 1 in treatment of BHP? Obviously we will like to block alpha 1 receptors. So alpha 1 blockers like prazosin, they are used for BHP. Clear? So alpha 1 present at 3 main locations: blood vessels, eye and prostatic urethra. Now coming to alpha 2 receptors. If you see, the receptors may be present here. Most of the receptors, like we discussed earlier, M1, M2, M3 and just now alpha 1. But some receptors are present here also. And alpha 2 is such a receptor. These receptors are postsynaptic, whereas this receptor is presynaptic. So alpha 2 is a presynaptic receptor. Now if you compare this system with a vehicle, with a car. So when we want to drive a car, we require two important things. One is accelerator. Second is brakes. Like when noradrenaline is released into the synapse, it stimulates these receptors that will produce the action. So this receptor, postsynaptic receptor, work like accelerator. It will produce the action. But we also require brakes in the car, because if we do not press the brakes, there may be accident. So this alpha 2 receptor act like a brake. That means whenever we stimulate alpha 2 receptors, it will inhibit the release of noradrenaline in the synapse. When noradrenaline do not come, sympathetic activity stops. So simply you need to remember that alpha 2 is acting like a brake. Alpha 2 acts like brake to sympathetic system. Alpha 2 acts like brake to sympathetic system. It is mainly presynaptic and acts like brake to sympathetic system. Now there are some alpha 2 receptor present here also, postsynaptic. And the postsynaptic alpha 2 receptors, they are indistinguishable from alpha 1 receptors. Means postsynaptic alpha 2 will work like alpha 1. That means if postsynaptic alpha 2 receptor is present in the blood vessels, they will cause vasoconstriction. If postsynaptic alpha 2 is present in the eye, they will cause mydriasis. So you can simply remember postsynaptic alpha 2 is equal to alpha 1. But they are very less, so no need to remember. But mainly you need to remember their action as a presynaptic receptor and they act like a brake. So alpha 2 receptors, their main function is to act like a brake. So alpha 1 receptor is present in blood vessels, eye and urethra, whereas alpha 2 is acting like a brake. Now coming to beta receptors. We have 3 receptors: beta 1, beta 2 and beta 3. Out of these, beta 3 receptor is mainly present on adipose tissue or fat cells. Adipose tissue or fat cells. And its main action is to cause lipolysis. Lipolysis. And we will not study beta 3 receptor anymore. Just remember it causes lipolysis. So effectively we have 2 beta receptors only, beta 1 and beta 2. And it is very easy to remember. You can remember we have 1 heart and we have 2 lungs. So beta 1 receptor is present in heart and beta 2 receptor is present in lungs. So beta 1 receptor is present in heart, means it will stimulate the heart. You know, beta 1 will stimulate the heart. Whereas beta 2 is in the bronchus, means it will relax the bronchus, it will cause bronchodilation. Now apart from heart, beta 1 is present at one more location, which is juxtaglomerular cells of kidney. So beta 1 receptor is present in heart and JG cells of kidney. In the heart it stimulates the heart, whereas in JG cells beta 1 receptor will result in secretion of renin. Whereas beta 2 receptor are present at most of the location, including the lungs. If you remember, in parasympathetic system we discussed M1, M2 and M3 receptors. The last receptor was present everywhere. So similarly here in sympathetic system also, the last receptor, which is beta 2, it is present everywhere. So first we'll write the important locations where beta 2 is present. Beta 2 is present in the lungs, means bronchus. It is present in the GIT. It is present in the urinary bladder. It is present in the glands. It is present in the uterus. It is present in the blood vessels. It is present in the skeletal muscles. It is present in the liver. The important locations of beta 2 receptors. As we discussed, sympathetic system stimulates the heart and relaxes most other parts of the body. And we know in the heart we have beta 1, so it is stimulatory. All other parts we have beta 2, so it is a relaxant. So most of these places beta 2 will cause a relaxation or inhibition. So it will relax the bronchus, it will relax the GIT, relax the bladder, relax the glands, relax the uterus. Relaxation of uterus is called tocolytic effect. Tocolytic effect. So in which disease we want to relax the uterus? It is used for preterm labor. If the labor pains start occurring before the maturity of the baby, we will want to relax the uterus, so we can give beta 2 stimulating drugs. It will relax the blood vessels also, so that means it will cause vasodilation. But important thing we discussed earlier, alpha 1 is causing vasoconstriction. So alpha 1 receptor was causing vasoconstriction, and just now we discussed beta 2 is causing vasodilation. So first of all, how to remember which receptor cause vasoconstriction and which receptor cause vasodilation. So to remember that, we have to go back to nursery class where we were taught about A, B, C, D. And in nursery class we were also told the counting 1, 2. Now just we need to put the arrows. So you can remember A1 means alpha 1, it will cause C means constriction. B2 means beta 2, it will cause D for dilation. So alpha 1 will cause vasoconstriction and beta 2 will cause vasodilation. So this we have remembered which receptor cause vasoconstriction, which cause vasodilation. Now the question is, both the receptors are of sympathetic system. So when sympathetic system is stimulated, what will happen to blood vessels? Because these two have opposite effects. So the effect on the blood vessel will depend upon which blood vessel has which receptor in more quantity. If a blood vessel contain more alpha 1 receptor, that will contract. If a blood vessel contain more beta 2, that will dilate. So alpha 1, if it is more, there will be vasoconstriction. If beta 2 is more, there will be vasodilation. Now the question is, which blood vessels contain more alpha 1 and which blood vessels contain more beta 2? Now this is also easy to remember. Now suppose a lion come in front of us. So what we can do at this time? Either we can fight with the lion and kill the lion. Obviously we are not Rajnikant to kill the lion. And the second, which is better option, is to run away. So when we see a lion, we will try to run away. And we can run away if we have power in the muscles. And we will also require power in the heart. So we do not get tired and we can easily run away. So whenever we want to run away in case of emergencies, we require sympathy. So sympathetic system will be activated and sympathetic system will help us in running away. That means when sympathetic system is activated, it should increase the blood flow to the muscles and increase the blood flow to the heart. So that means blood vessels of heart, which is coronary arteries, and blood vessels of skeletal muscles, they should dilate when there is sympathetic overactivity, and dilation will occur when there is more beta 2. So skeletal muscles and coronary arteries, they contain more beta 2 as compared to alpha 1 receptors. So that means whenever sympathetic system is overactive, we can quickly run away. The question is, normally we have 5 liters of blood in the body. When a lion come in front of us, it will not become 10 liters. So when the blood remains 5 liters from where it comes. So what happens is, at all other blood vessels, alpha 1 is more. Blood vessels of skin, blood vessels of internal organs, they contains more alpha 1 receptors. So whenever there is an emergency, there will be vasoconstriction in these areas because alpha 1 is more. and this blood is shifted to heart and muscles so person can run quickly. So alpha 1 receptor is more in skin and internal organs, whereas beta 2 is more in the blood vessels of heart and muscles. So this is effect of sympathetic system on the blood vessels. Now next is skeletal muscles. Apart from the blood vessels, beta 2 receptor is also present on the skeletal muscle spindle, and stimulation of beta 2 receptor in the muscle spindle result in tremors. That's why whenever there is sympathetic overactivity, there is presence of tremors. Like we develop tremors when the lion comes in front of us. We develop tremors in Viva exams because sympathetic system is overactive. We also develop tremors while proposing someone, again because sympathetic system is overactive. Sympathetic activity lead to tremors. Now lastly, there is presence of beta 2 in the liver. Now before discussing the action of beta 2 in the liver, we need to answer some important questions. Which is more dangerous, hypoglycemia or hyperglycemia? Obviously, hypoglycemia is more dangerous. Hyperglycemia means diabetes. You must have seen many diabetic patients who have uncontrolled blood sugar and they do not develop problem for many years. But hypoglycemia, if it is present for just 1 minute, the person will go to coma. So hypoglycemia is an emergency. So sympathetic system help us in protecting from emergencies. So sympathetic system will try to protect us from hypoglycemia. So how it will protect? So whenever the person develop hypoglycemia, sympathetic system will become overactive. And whenever sympathetic system is overactive, it will stimulate beta 1, beta 2, and in case of sweat glands, sympathetic cholinergic system. So when beta 1 is stimulated, the person will develop tachycardia, heart is stimulated. And when severe tachycardia occurs, it can lead to palpitations. Stimulation of beta 2 we just discussed will lead to tremors. And stimulation of sympathetic cholinergic fibers in the sweat glands will lead to sweating. So when a person develops sympathetic overactivity, as in case of hypoglycemia, the person will develop tachycardia, palpitation, tremors and sweating. So these are called as warning symptoms of hypoglycemia. Warning symptoms of hypoglycemia. That means hypoglycemia itself tells that I am present by causing these symptoms. Remember, hypoglycemia is more likely in diabetic patients. So if they skip meals, if they take anti-diabetic drug, they may develop hypoglycemia. So whenever they develop hypoglycemia, these symptoms will come. These are the warning symptoms. That means whenever these symptoms come, the person should take sugar or biscuit. So hypoglycemia will be reversed and person will not go to coma. This is very important. Warning symptoms of hypoglycemia. So this should be told to every diabetic patient. Now suppose a person comes to a doctor like me who is not aware about these symptoms. We do not tell him anything about these symptoms. When these symptoms are not told, so person will not take sugar. So person has all these symptoms but the person do not take any sugar. So what will happen? Will the person go to coma? No, still the person do not go to coma because now the beta 2 receptor which is present in the liver will be stimulated. And we know liver is site of metabolism. So when beta 2 is stimulated in the liver, it will shift the metabolism in such a way that blood sugar start increasing. That means all the biochemical processes which are forming blood glucose will be stimulated and which are consuming will be inhibited. So there will be stimulation of gluconeogenesis. There will be stimulation of glycogenolysis. There will be inhibition of glycogenesis. So basically, by changing the metabolism, it will increase blood sugar. And when blood sugar increases, the hypoglycemia will be reversed. So that's why sympathetic system is very, very important to protect from hypoglycemia. It protects by two main mechanisms. One by causing a warning symptom and second by reversing the hypoglycemia. This is the reason that if we give beta blocker to a diabetic patient, they are very dangerous drugs, because if we give beta blocker to a patient who has diabetes, first of all the symptoms will not come, so they result in masking of warning symptoms. That means even if the person develops hypoglycemia, the symptoms will not come. The person will never come to know that he is having hypoglycemia. So the person will not take sugar. Now second thing, if a person do not take sugar, the liver will reverse the hypoglycemia, but we have blocked the same receptor. That means even reversal cannot happen. So there is high chance that the person can go into coma. So beta blockers are contraindicated in diabetic patients. Beta blockers are contraindicated in diabetic patients. Now one very important question which is asked is, which symptom of hypoglycemia will be present even if a person is taking beta blockers? The answer is sweating. Remember, sweating is mediated by acetylcholine, that means M3 receptors, and we have blocked beta 1 and beta 2 only. So sweating is the only reliable symptom of hypoglycemia in diabetic patient taking beta blockers. Even if beta blocker is taken, sweating still will be present. So we have discussed the location of different sympathetic receptors. So alpha 1 receptor, it is present in the blood vessels, eye and urethra. Alpha 2, the main function is to act like a brake. Beta 1 is mainly present in heart and JG cells, and rest everywhere beta 2 receptor is present. So with this basic understanding, now we can discuss the drugs acting on these receptors. Just like parasympathetic system, the drugs acting on sympathetic system, they can also be divided into sympathomimetics and sympatholytics. Sympathomimetics are those which stimulate the sympathetic system, and sympatholytics are those which block the sympathetic system. So we will start the discussion from sympathomimetic drugs. Now sympathomimetic drugs, they are further classified into directly acting and indirectly acting. Directly acting will stimulate any of those receptors, alpha 1, alpha 2, beta 1, beta 2. Whereas indirectly acting drugs are of two main types. One we already discussed, the drugs which can inhibit the reuptake. If a drug inhibits the reuptake of noradrenaline, it will increase sympathetic activity. And the main drug which acts by inhibiting the reuptake of noradrenaline is cocaine. Another drug is tricyclic antidepressants. These drugs will cover later on. Cocaine will cover in anesthesia, and tricyclic antidepressants will cover in CNS. Now second group of drugs which act by in indirect action is drugs acting by displacement. Drugs acting by displacement. The example is tyramine. Tyramine. First of all, how tyramine works? Now we know that noradrenaline is stored in this vesicle, and every vesicle has a fixed capacity. Suppose this is able to store 50 molecules of noradrenaline. So normally all of them are neurotransmitter. If we give a drug like tyramine, which has the capacity to enter the vesicle, suppose we give 25 molecules of tyramine. So these 25 molecules of tyramine will enter the vesicle. So total will become 75 molecules in the vesicle, but it cannot store 75. So what will happen is, it will displace 25 molecules of noradrenaline in the synapse, which will start working on the receptors, and that will produce the sympathetic action. So this is called action by displacement. Drug will enter the vesicle and push noradrenaline into the synapse to produce the action. Now what is remaining in the vesicle is 25 molecules of tyramine and 25 molecules of noradrenaline. If we give second dose of tyramine, 25 more molecules, so total will become 50 tyramine in the synapse and 25 noradrenaline. Again 75 it cannot store, so these 25 will also be displaced, and again sympathetic action will come. Now what is remaining in the vesicle is all 50 molecules of tyramine. If we give third dose of tyramine, 75 tyramine will become. Now there is no noradrenaline which can be displaced, so now tyramine is displaced. So when tyramine comes in the synapse, it cannot act on the receptor, so the action will suddenly stop. So this phenomenon is known as tachyphylaxis. Tachyphylaxis. It is divided into two parts. Tachy means fast, phylaxis means tolerance. So when we give a drug like tyramine, they will produce action for 2 or 3 doses, but after that suddenly the tolerance will occur to their action. Remember, normally tolerance is slow to develop, but in these drugs the tolerance is very rapid to develop. So tyramine like drugs, they act by displacement, and all the drugs acting by displacement can show the phenomenon of tachyphylaxis. So apart from tyramine, the other drugs which act by displacement are, we have tyramine, ephedrine, pseudoephedrine and amphetamines. Out of these, tyramine, it acts by displacement only this mechanism, indirect action, it causes displacement of noradrenaline, whereas the other 3 drugs, ephedrine, pseudoephedrine and amphetamines, although they also cause a displacement, that means indirect effect is there, but after some time when they come in the synapse, they can also act on the receptors, means they have mixed action, they have both direct effect as well as indirect effect. Clear? Now important points regarding the individual drugs. Tyramine is present in large quantities in cheese. Cheese contains plenty of tyramine. The clinical importance we will discuss little while later. Next 2 drugs, ephedrine and pseudoephedrine, they act as nasal decongestants. So they are used in cold when the nasal congestion is present. And lastly, amphetamines. Amphetamines are the drugs which can cross the blood-brain barrier. So they enter the brain and they produce 2 important effects. One, they reduce sleep, and second, they increase attention span. So they reduce sleep and increase attention span. So that means they are which type of drugs? Yes, they are called CNS stimulants. Amphetamines are CNS stimulants. They reduce sleep and increase attention span. So the use of amphetamines, although amphetamines are highly addictive drugs, but the use is based on these 2 functions only. The first function is they reduce sleep, and this action is utilized in a condition called narcolepsy. Narcolepsy is a disease which is characterized by sleep attacks. In narcolepsy, the patient develops sleep attacks. And sleep attacks literally means attacks. The person can suddenly sleep. So you can assume a person is driving a bike, suddenly sleeps. A person is swimming, suddenly sleeps. So it can lead to fatal accidents. So we do not want these sleep attacks. So we give a CNS stimulant drug like amphetamines. They decrease sleep, so that will lead to decrease in number of sleep attacks. Now second action of increasing the attention span, it is utilized in a disease called attention deficit hyperkinetic disorder, ADHD. Attention deficit hyperkinetic disorder. This is a disorder seen commonly in children. Attention deficit does not mean that parents are not giving attention. Attention deficit means child has less attention span. Less attention span means the child is not able to concentrate on anything. So when the child is not able to concentrate, the child get bored easily. So a child start playing with some game, not able to pay attention. So the child get quickly bored. So child will take another game and start playing again. So again get bored. So again start playing with another game, again bored. So after some time the child will think that I have nothing to play. So the child become irritable and that lead to hyperactivity. So hyperactivity is indirect result of inattention. So primary problem is inattention, that is leading to irritation and that is leading to hyperactivity. So in ADHD the primary problem is inattention. So when we give amphetamines, they increase the attention span. So that will treat the ADHD. And the drug of choice for ADHD is methylphenidate. Methylphenidate is a drug of choice for ADHD. Clear? So that is all about the indirectly acting sympathetic drugs. So drugs acting by inhibiting the reuptake and drugs acting by causing the displacement. Now we'll move to directly acting drugs. The drugs will directly stimulate any of the sympathetic receptors, alpha 1, alpha 2 or beta 1 or beta 2 receptors. Now directly acting drugs, we can divide them into catecholamines and non-catecholamines. Directly acting drugs may be divided into catecholamines and non-catecholamines. The first question is, what is a catecholamine? Catecholamine is actually a chemical name which consists of catechol and amine. If you remember chemistry, this chemical structure of dihydroxybenzene, it is also known as catechol. And if amine group is also present, it becomes catecholamine. That means any drug having this type of chemical structure is called catecholamine. If this is absent, it is called non-catecholamine. The question is, we have already discussed so many drugs, but we never talk about the chemical structure. But here we are dividing the drugs based on the chemical structure. So there must be something important. And important thing is that this chemical structure of catecholamine, it can be recognized by some enzymes in the body. And the name of those enzymes are COMT, catechol orthomethyl transferase. So this enzyme can recognize any drug which contains this chemical structure. And this enzyme is present in large quantities in GIT. So that means if any person takes any catecholamine orally, already COMT is waiting there to break it down. So no catecholamine will be effective orally. So that is the only important thing to know, that catecholamines are not effective orally, whereas non-catecholamines may be effective orally. Now catecholamines, they are further divided into endogenous catecholamines and exogenous catecholamines. Endogenous catecholamines means they are normally present in the body, whereas exogenous means they are given from outside only. The endogenous catecholamines include adrenaline, noradrenaline and dopamine. Adrenaline, noradrenaline and dopamine, they are endogenous catecholamines, whereas exogenous catecholamines include dobutamine, isoprenaline, and phenoldopa. Adrenaline, noradrenaline and dopamine are endogenous, whereas dobutamine, isoprenaline and phenoldopa are exogenous catecholamines. So first we'll cover catecholamines, then we will move to non-catecholamines. So among these drugs, we'll start the discussion from dopamine. Dopamine. Now for knowing about any drug, the most important thing is to know about on which receptors it works. Dopamine work on three main receptors. These are D1, beta 1 and alpha 1. Important thing is in this sequence. Sequence means at a very low dose it stimulates D1. When we increase the dose, it will start stimulating D1 and beta 1 both. And at high dose it can stimulate all three receptors. So if you remember the dose for beta 1, other two you can automatically remember. The dose of dopamine for stimulation of beta 1 receptors is 2 to 10 microgram per kg body weight per minute. So if we give dopamine infusion at a rate of 2 to 10 microgram per kg body weight per minute, it can stimulate beta 1. That means if we give it less than 2, it will stimulate only D1. If we give more than 10, it can stimulate all three receptors. Now we already discussed about beta 1 and alpha 1. Beta 1 is mainly present in heart and alpha 1 is mainly present in the blood vessels to cause vasoconstriction. Now we did not discuss about D1 receptors. D1 receptors are also present in blood vessels, but their main function is to cause vasodilation. D1 receptors are present in all the blood vessels of the body and they cause vasodilation, but they are highest concentration in the renal blood vessels. They are present in all the blood vessels, but maximum concentration is present in the renal blood vessels. So when we give dopamine, it can stimulate D1, beta 1 and alpha 1. So based on that, we can find the uses of dopamine. Like dopamine stimulate the beta 1 receptors, means it will stimulate the heart. So in which condition we will want to stimulate the heart? Yes, we want to stimulate the heart in congestive heart failure. So dopamine is used in congestive heart failure and the dose of dopamine will be 2 to 10 microgram per kg body weight per minute. Now dopamine can also stimulate alpha 1 receptor which will cause vasoconstriction. So in which disease we will want to cause vasoconstriction? Yes, we'll want to cause vasoconstriction in patients with shock. So dopamine, when given in high doses, will cause vasoconstriction that will increase the blood pressure so it can treat shock. But the additional advantage of dopamine is at high doses it stimulates all the three receptors. That means it will stimulate D1 receptors also. And by stimulating the D1 receptor, it will cause vasodilation in kidney. When vasodilation occurs in the kidney, GFR increases. And when GFR increases, that will lead to more urine outflow. So dopamine in particular is drug of choice for a patient having shock with oliguria. It will treat not only shock, but it will also reverse the renal failure. So dopamine is a drug of choice for patient with shock and oliguria. Shock plus oliguria, dopamine is drug of choice. So that is the important thing to remember about dopamine. One more thing you can find out, the drug whose name contains dopa, it will stimulate D1 receptor. If dopa is not present in the name, it will not stimulate D1 receptor. Now why we are talking like that? The second drug we are going to discuss, the name is very similar to dopamine, dobutamine. But if you see carefully, dobutamine do not contain dopa in the name. So dobutamine do not act on D1 receptors. So that is the most important thing to remember. Dobutamine do not act on D1 receptors. Rather, dobutamine primarily work on beta 1 receptors. Dobutamine mainly stimulate beta 1 receptors. Because it is mainly acting on beta 1 receptors, so it is mainly used for congestive heart failure. So major use of dobutamine is congestive heart failure. It stimulates mainly beta 1 receptors. Now if you see another drug, phenoldopam, see it carefully, its name also contains dopa. Phenoldopam also contains dopa in the name. So that means it will also stimulate D1 receptor. If you read the name again, phenoldopam, it will look like only dopa. That means only dopa means it stimulates only D1 receptor. Unlike dopamine, which at high doses starts stimulating beta 1 and alpha 1 receptors also, phenoldopam even at high dose stimulates only D1 receptors. So when it stimulates only D1 receptor, it will cause only vasodilation. And when it is causing vasodilation, we can utilize it in hypertensive emergencies. So phenoldopam can be used in hypertensive emergencies. It will cause vasodilation and treat the hypertensive emergencies. So that is all about the dopamine, dobutamine and phenoldopam. Now we are left with the three drugs in this category. These are adrenaline, noradrenaline and isoprenaline. We will cover all the three drugs together. Adrenaline, noradrenaline and isoprenaline. Adrenaline is also called as epinephrine. Noradrenaline is also called as norepinephrine. Now, for knowing about these drugs, again the most important thing is to remember on which receptors they work. And it is very easy to remember. You can remember A for adrenaline, A for all the receptors, A for all the receptors. All the receptors means alpha 1, alpha 2, beta 1, beta 2. We have four main receptors. So adrenaline stimulates all the four receptors. Then second is Na means noradrenaline. So you can remember Na means not all. So we will start writing alpha 1, alpha 2, beta 1 and suddenly we will remember that not is also written. So we will not write beta 2. So it acts on three only, alpha 1, alpha 2 and beta 1. Now isoprenaline it acts only on beta receptor, beta 1 and beta 2 only. So adrenaline act on all the 4 receptors. Noradrenaline not all, that means last receptor it will not work, and isoprenaline only beta receptor. Clear? So now we can discuss the effect of these drugs on blood pressure and heart rate. Effect on BP and effect on heart rate. Now blood pressure is of two types, systolic and diastolic. Systolic BP and diastolic BP. So as the name tells, systolic blood pressure, systole means contractility of heart, and heart contractility of heart depend upon which receptor? Yes, it depends upon beta 1 receptors. So if a drug stimulates beta 1, it will stimulate the heart, so it can increase systolic BP. And if we see which drugs out of the 3 stimulate beta 1 receptors, adrenaline stimulate beta 1, noradrenaline also stimulate beta 1, isoprenaline also stimulate beta 1. So all 3 stimulate beta 1, means all 3 will increase systolic blood pressure. So all the 3 drugs, they tend to increase systolic blood pressure by stimulating beta 1. Now the question is, what will the effect on diastolic blood pressure? Diastole means when heart is relaxing. When the heart is relaxing, now which factor maintain the blood pressure? Which factor? Peripheral vascular resistance. So in simple manner, peripheral vascular resistance means effect on the blood vessels. If there is vasoconstriction, there is more BP. If there is vasodilation, there will be less BP. So that is diastolic blood pressure. So diastolic blood pressure depend upon blood vessels. And which receptor is present on blood vessels? Yes, we have 2 receptors, alpha 1 and beta 2, which have opposite effects. Remember nursery class, we discussed A, B, C, D. Alpha 1 cause constriction, beta 2 cause dilation. So it will depend upon alpha 1 and beta 2. And if you see, adrenaline act on alpha 1 as well as beta 2. That means by stimulating alpha 1 it causes vasoconstriction, and by stimulating beta 2 it will cause vasodilation. So the 2 will tend to cancel each other. So the net effect will be negligible. Neither much increase nor much decrease. On the other hand, noradrenaline stimulates alpha 1 which cause vasoconstriction, but it has no effect on beta 2. That means only vasoconstriction. Only vasoconstriction means it will increase the diastolic BP. Lastly, isoprenaline do not act on alpha, only act on beta 2. Beta 2 we know is causing vasodilation, and vasodilation will lead to decrease in diastolic blood pressure. So we noted that all the 3 drugs have different effects on blood pressures. Adrenaline has negligible effect, noradrenaline increased diastolic BP, and isoprenaline decreased diastolic BP. Systolic BP increased by all 3, but diastolic BP all 3 have different effects. So now we can discuss the effect of these drugs on heart rate. Now one thing to remember, whenever we discuss the effect of any drug on heart rate, we always discuss under 2 headings. First, what is the direct effect on heart? And second, what is the indirect effect on heart? Now starting with the direct effect on heart. So direct effect on the heart means the drug will directly go to heart and stimulate its receptors or inhibit its receptors. And which receptor is present on the heart? Yes, it is beta 1 receptor. So any drug which stimulates beta 1 receptor will stimulate the heart, increase the heart rate. And we discussed already all 3 drugs stimulate beta 1 receptors. So all 3 drugs will try to increase heart rate by direct action. All 3 drugs increase heart rate. Now what is this indirect effect? Now indirect effect is the compensatory response of the body. Remember, our body has compensatory ability for everything. If anything goes wrong in the body, our body will try to rectify that automatically. So that is called as indirect effect. Now if the BP increases, body will try to decrease the BP. If the BP decreases, body will try to increase the BP. But for that, body should contain some sensor which can tell that BP is increased or decreased. Only then the body can change the BP. So that sensor is present in the blood vessels, and name of that sensor is baroreceptors. So blood vessel contains baroreceptors. Baroreceptors. Now which blood pressure baroreceptors sense? as they sense mainly mean blood pressure. But as we know, mean blood pressure, the major component is diastolic BP. So you must be knowing the formula. Mean blood pressure is equal to diastolic blood pressure plus 1/3 of pulse pressure. So the major component of mean BP is diastolic BP. So we can safely assume that baroreceptors mainly sense diastolic blood pressure. So what happens when the diastolic blood pressure increases? When diastolic BP increases, baroreceptors get the information. So baroreceptors are stimulated. And whenever baroreceptors are stimulated, they will immediately pass this information to the CNS, brain and spinal cord. Baroreceptor pass this information to CNS with the instruction that diastolic BP is more, please reduce this BP. But our CNS has only two arms, one is sympathetic system, one is parasympathetic system. So as the information is we have to reduce the BP, so which arm will be stimulated? Yes, it will be parasympathetic system. So whenever the diastolic BP increases, it will stimulate the parasympathetic system. And what is the effect of parasympathetic system on heart rate? It decreases heart rate. So this is the indirect effect on heart rate. So whenever diastolic BP increases, it stimulates the baroreceptors. Baroreceptors stimulate the parasympathetic system of the CNS, and that will result in decrease in heart rate. The opposite is also true. Whenever diastolic BP decreases, when diastolic BP decreases, again baroreceptor get the information. They pass the information to CNS with the instruction that BP is low, kindly increase the BP. And for increasing the BP, the CNS will stimulate the sympathetic system. And when sympathetic system is stimulated, the heart rate increases. So this is the indirect effect on heart rate. So if you see carefully, whenever diastolic BP increases, the indirect effect is decrease in heart rate. Whenever diastolic BP decreases, the indirect effect is increase in heart rate. Increase in diastolic BP will decrease the heart rate. Decrease in diastolic BP increase the heart rate. So you can safely remember that indirect effect on heart rate is opposite to diastolic BP. If diastolic BP increases, heart rate decreases. If diastolic BP decreases, heart rate increases. So if we put this in the table, adrenaline, it has no effect on diastolic BP. So there will be no indirect action also. Noradrenaline, it increases diastolic BP. So indirect effect on heart rate will be opposite. That means it will decrease heart rate. Isoprenaline decrease diastolic BP. So indirect effect will be to increase heart rate. So if we see the final effect on heart rate, it will be simple arithmetic sum of these two heart effects, direct and indirect effect. So adrenaline 1 plus 0 is equal to 1. Noradrenaline 1 minus 2 will be minus 1. Isoprenaline 1 plus 2 will be 3. So final effect on heart rate, adrenaline increase the heart rate, noradrenaline decrease the heart rate, and isoprenaline significantly increase the heart rate. Now this table is very, very important for MCQ points of view. So some of the important questions which are asked from this table. First question is, which drug increase systolic as well as diastolic BP but cause bradycardia? The answer is noradrenaline. Systolic and diastolic BP is increased, but bradycardia occurs. Second question which is asked is, which of the following drug can cause maximum tachycardia? The answer is isoprenaline. Isoprenaline cause maximum tachycardia. One more question which seems very simple, but highly likely that the question can be marked wrongly. Simple question is, what is effect of noradrenaline on heart rate in a normal person? Yes, it will cause bradycardia. When it is so simple, why it is likely to be marked wrongly? The reason is, this table is not present in front of our eyes during the exam. At that time, we were simply thinking like noradrenaline is a sympathetic drug, so it should cause tachycardia. But what is actually happening is, noradrenaline is a sympathetic drug, but it is causing bradycardia because indirect effect is very strong. So remember, noradrenaline do not cause tachycardia, it causes bradycardia. Next question, which is slightly difficult. is what is effect of noradrenaline on heart rate in a patient with transplanted heart. Now to answer this question, we need to know the difference between a normal heart and a transplanted heart. The main difference is that a normal heart and transplanted heart, otherwise they are very similar. That means both contain beta 1 receptors. But the main difference is that in a transplanted heart, we are taking the heart from one person's body and putting it in some other person's body. So when we are putting the heart in other person's body, we will not be able to make small neural connections. So that means those sympathetic parasympathetic fibers cannot be joined. So that means a transplanted heart will not show any indirect effect because there is no sympathetic or parasympathetic supply to that. So in a transplanted heart, indirect action do not come. Only direct action comes. So when only direct action comes, the effect of noradrenaline will be to cause tachycardia. So this is important to remember. In a normal person, noradrenaline causes bradycardia, but in a patient with heart transplantation, noradrenaline causes tachycardia. The reason is simple. In a transplanted patient, indirect effect do not manifest. So now we can discuss the uses of these drugs, and again they are easy to remember. Just from the receptors you can remember the uses. So we have adrenaline, we have noradrenaline, we have isoprenaline. Isoprenaline act on beta 1 and beta 2. Noradrenaline, not all we discussed, alpha 1, alpha 2, beta 1. And adrenaline A for all means alpha 1, alpha 2, beta 1, beta 2. So starting from isoprenaline, it stimulates the beta 1 receptors which are present in heart. So isoprenaline is used to stimulate the heart for congestive heart failure. It stimulates the beta 2 receptors. So we can utilize this in bronchial asthma. The beta 2 cause bronchodilation. So in asthma we want to cause bronchodilation. So we can use in CHF, we can use in some patients of asthma. Now noradrenaline, it stimulates alpha 1 receptor which will increase the blood pressure. So we can use it in shock. It also stimulates beta 1 receptor. So we can use it in congestive heart failure. Adrenaline, technically speaking, it stimulates all the receptors. So can be used for almost all these indications, shock, CHF, asthma. But practically, adrenaline has very few uses. The reason is adrenaline is very toxic. Slight overdose can cause arrhythmia and the person can die. So adrenaline has specific uses only, and the important uses of adrenaline to remember. Adrenaline is a drug of choice for anaphylactic shock. Adrenaline is a drug of choice for anaphylactic shock. Drug of choice for anaphylactic shock. The first question is, in this condition there is shock. That means BP is low. So we want to increase the BP. If we look at the table, we'll find that for increasing the blood pressure, noradrenaline is a better drug. It increases systolic as well as diastolic BP. Whereas adrenaline is mainly acting on systolic BP, has negligible effect on diastolic BP. So then why do we prefer adrenaline, not noradrenaline? Noradrenaline is better to increase BP, so we should use noradrenaline. But adrenaline is preferred, adrenaline is drug of choice. The reason is anaphylaxis is also written in this case. And anaphylaxis mostly manifests as bronchoconstriction. So that means to treat the anaphylactic shock, we need to cause bronchodilation also. Remember the difference between adrenaline and noradrenaline? A for all and A for not all. That means noradrenaline do not act on beta 2 and it cannot cause bronchodilation. So if we give noradrenaline, it will increase the BP, but the person may die because of respiratory problem. On the other hand, adrenaline stimulates all the receptors, so it can treat shock also and it can cause bronchodilation also. That's why adrenaline is a drug of choice for anaphylactic shock. Now, route of choice is intramuscular. Adrenaline is preferred by intramuscular route. If that is not given in the option, then you can mark subcutaneous. But remember, IV should not be the answer because intravenous adrenaline is highly arrhythmogenic. It can lead to death of the person. The route of choice is intramuscular. If not in the options, then subcutaneous. Now, third important question, what is the concentration of choice? The concentration of adrenaline used is 1:1000. 1:1000 means 1 gram of adrenaline is dissolved in 1000 ml of solution. 1 gram adrenaline is dissolved in 1000 ml of solution, and 0.5 ml of this solution is given as intramuscular dose. So 0.5 ml of 1:1000 solution is dose. So route of choice is intramuscular, drug of choice is adrenaline, and concentration of choice is 1:1000 ml. 99% of the patient will improve with this dose. If a person do not improve, then we need to repeat. If a person do not improve, then repeat the same intramuscular dose, but important thing is within 10 minutes. It is a serious condition, we cannot wait for long time, so we need to repeat adrenaline within 10 minutes. Most of the people will respond to that dose. If still the person do not respond, then in the desperate circumstances we can give IV adrenaline. But IV adrenaline, the concentration used should be 1:10,000. That means we need to dilute it 10 times, only then we should give intravenously. 1:1000 IV adrenaline will cause arrhythmia and the person may die. So if we use intravenous, it is 10 times diluted, and the indication of intravenous is when the intramuscular route has failed repeatedly. So that is the adrenaline and anaphylactic shock. Adrenaline is a drug of choice for anaphylactic shock. Now apart from anaphylactic shock, second use of adrenaline. Adrenaline is also used in cardiac arrest. Now what do you mean by cardiac arrest? Cardiac arrest means heart has totally stopped. Heart is not working at all. So when the heart is not working, what will be the clinical presentation of the patient? Obviously the person will be unconscious. No blood is going to brain, person is unconscious, not responding. There will be no pulse, there will be no heart rate. Clear? So that means the person is almost dead. So what we will do in this person which has no pulse, no blood pressure, no heart rate, person is not responding at all. So what we will do? Yes, we will give basic life support, or in simple language what we say, CPR, cardiopulmonary resuscitation. So how to do CPR? What is the sequence of events? The sequence of events is CAB. C means chest compressions. First we will give chest compression because heart is not contracting. So what we need to do is from outside we will press the heart through the ribs and compress the heart against vertebra so that heart can be squeezed and the blood can go out. Clear? So chest compressions. Second thing is airway patency. We need to open the airway. And third is breathing. Through that open airway we can give breathing through ambu bag or ventilator or mouth to mouth breathing, whatever is available. Okay? So we will start CPR. Cardiopulmonary resuscitation. We start giving chest compressions, airway and breathing. Now have you ever given CPR to any person? If you have given or you have seen someone giving, CPR is a very tiring job. Like we need to compress the heart against the ribs. It requires a lot of power. It requires a lot of effort. And plus we need to give 100 times every minute. So that means we need to press the heart strongly 100 times in 1 minute, and the person will tire very easily. While giving CPR, just in 2 minutes or 3 minutes, it seems like we have run a marathon. We are so much tired. Okay? So we have started doing CPR, but the person is not responding. So then we try giving the drugs. And the drug which we use is adrenaline. Adrenaline. By which route adrenaline is given for CPR? It is given intravenously. Adrenaline is given intravenously for cardiopulmonary resuscitation. So what will be the concentration of adrenaline when we give it IV? Yes, the concentration of adrenaline is 1:10,000. Remember in anaphylactic shock, when we give intramuscular it was 1:1000, but when we give it IV it was 1:10,000. The same here, when we give intravenously it is 1:10,000. Now suppose we are not able to find the vein. Remember, the person is unconscious, but heart is not pumping, the veins must have collapsed. So high chances that we will not be able to find a vein. So when we are not able to find the vein, then how we will give adrenaline? Yes, in that case we will give adrenaline by intraosseous route. So the preferred route is IV. If it is not possible, then we give intraosseous. Intraosseous means we have a special needle. Through that needle we will inject adrenaline in the tibia. The venous plexus around the long bones is usually patent even in such circumstances, so adrenaline can be absorbed from there. Now suppose we are not able to find the vein, we cannot give IV, and we do not have the needle to give in the trachea, so intraosseous is also not possible. Then what we will do? By which route you will give adrenaline? The third example is endotracheal. We will intubate the person and through the endotracheal tube we will inject adrenaline. So these are the routes in this sequence. And when will you use intracardiac adrenaline? Intracardiac adrenaline is given only in one situation, that is in Hindi movies. Remember, intracardiac adrenaline has been banned long ago. In 2005 it was banned. Intracardiac adrenaline is not given at all. Okay? The preferred route is IV, if not possible intraosseous, if not possible endotracheal. Okay? So these are the two important uses of adrenaline: anaphylactic shock and cardiac arrest. Okay. Now we'll move to one very important phenomenon which is called as vasomotor reversal of tail. Now to understand this, first of all we'll again discuss adrenaline. We discussed has action on 4 receptors: alpha 1, alpha 2, beta 1, beta 2. And out of these 4 receptors, which receptors are present on the blood vessels? Yes, alpha 1 and beta 2. And they have opposite effects. Remember, we discussed A, B, C, D. So alpha 1 will cause vasoconstriction and beta 2 causes vasodilation. Now one more important thing to remember now is alpha 1 receptor is a strong receptor, whereas beta 2 receptor is a sensitive receptor. Now what is the meaning of this thing is, beta 2 is sensitive means even if we give low dose of adrenaline, it can stimulate beta 2. But that low dose cannot stimulate alpha 1. So alpha 1 requires high dose. So when we give high dose of adrenaline, both beta 2 and alpha 1 will be stimulated. And when both are stimulated, alpha 1 will have more effect because it is a strong receptor. So if we give low dose adrenaline, it stimulates only beta 2, which will lead to vasodilation. But if we give high dose adrenaline, it stimulates alpha 1 and beta 2 both. But the effect of alpha 1 will predominate, so the net effect will be vasoconstriction. Now to understand this more easily or more effectively, we will make it mathematical. Suppose alpha 1, beta 2 receptors, they are sensitive, so they can be stimulated by just 10 molecules of adrenaline. Whereas alpha 1 cannot be stimulated by low dose. So stimulation of alpha 1 suppose require 50 molecules of adrenaline. So if we give 100 molecules of adrenaline by IV route, if we give 100 molecules of adrenaline by IV route, which receptor will be stimulated? So both will be stimulated, alpha 1 and beta 2. And when both are stimulated, the net effect will be due to alpha 1 receptor, because that is a strong receptor. So this is the normal blood pressure. When adrenaline high dose is given, 100 molecules are given, BP increases. Now why BP increases? Although it is stimulating both alpha 1 and beta 2, alpha 1 is a more strong receptor as compared to beta 2. So that lead to increase in blood pressure. But after some time, the metabolism will start. These 100 molecules, they will be metabolized to 90, then 80, then 70. So this effect will keep on decreasing. Now will it stop here? No, it will not stop here, because when it is metabolized to less than 50, so when the 49 molecules of adrenaline remains, remember they cannot act on alpha 1 now, but all 49 can act on beta 2. And when beta 2 is stimulated, it will result in vasodilation. So the BP falls. So this fall is due to beta 2. But these 49 will also be metabolized. So from 49 they become 40, 30, 20. So this effect will also start decreasing. And when they become less than 10, even beta 2 will not be stimulated, BP will come back to normal. So that means when we give adrenaline by IV route in high dose, there will be two phases in the response. First the BP increase, then the BP decrease. So initial increase in BP is due to alpha 1, later on fall in BP is due to beta 2. This is known as biphasic response of adrenaline. Biphasic response means first BP increase, then BP decrease. Clear? Now suppose we give adrenaline high dose, and before that we have already given alpha blocker. So we give high dose of adrenaline with alpha blocker, what will happen? So first thing what will happen is when we give 100 molecules of adrenaline with alpha blocker, so this increase in BP cannot come because alpha 1 is already blocked. So right from the beginning the BP will start decreasing. BP will start decreasing. Now second thing, will this decrease be only till this place? No, the BP will be more reduced. The decrease will be exaggerated because this decrease was caused by 49 molecules. But this will now all 100 are acting on beta 2. They cannot act on alpha 1. So two things we note. One, biphasic response is absent, only fall occurs. Second, this fall is exaggerated. So normally when we give adrenaline high dose, we will expect that BP will first increase. But when we give adrenaline with alpha blocker, only decrease occur. So opposite to what we were expecting has happened, and this opposite is known as reversal. So this phenomenon is called as vasomotor reversal. Vasomotor means on the muscle of the blood vessel effect is reversed. Instead of vasoconstriction, vasodilation occur. It was first noted by scientist Henry Dale. So it is called vasomotor reversal of Dale. Clear? Now coming to most important question. We never give adrenaline intravenously. Then what is the use of reading this phenomenon? We will not give IV adrenaline. Then why to talk about this? The reason is we do not give intentionally, but in patients with pheochromocytoma, which is tumor of adrenal medulla, large amount of adrenaline can be secreted into blood. So if large amount of adrenaline is secreted into blood, means it will be stimulating both alpha 1 and beta 2. But as alpha 1 is predominant, so the effect is this. So patient of adrenaline secreting pheochromocytoma has very high BP. Normally when the BP is high, we will give alpha blocker to reduce the BP. So in this patient, if we give alpha blocker, now what will happen is vasomotor reversal will occur. Because high dose adrenaline is present, we have given alpha blocker. So instead of BP becoming normal, the BP will fall very low and the person will develop severe shock and the person can die because of this. So important thing is if there is adrenaline producing pheochromocytoma, only alpha blockers can be very dangerous because they can result in vasomotor reversal of Day. That is the clinical importance to know about vasomotor reversal of Day. Clear? In patients of pheochromocytoma, there is excessive amount of adrenaline which can come into the blood. So vasomotor reversal comes here. Clinically important is at this point. So we'll try to understand first. Pheochromocytoma is a tumor of adrenal medulla. So there may be two type of patients. One in which the tumor is predominantly secreting adrenaline. Second in which the tumor is predominantly secreting noradrenaline. So two type of patients are there. Now in both the cases, whether it is adrenaline producing or noradrenaline producing tumor, both are sympathetic substances, both will cause vasoconstriction, both will stimulate the heart, so BP increases. So in both cases the blood pressure will be high. So adrenaline containing tumor also, noradrenaline containing tumor also, the BP is high. Suppose the person is having blood pressure of 180 here, 180 here. And we know adrenaline stimulate alpha 1, alpha 2 and beta, noradrenaline stimulate alpha 1, alpha 2 and beta 1, and adrenaline A for all stimulate all the receptors. In both the cases, the BP is high, and we know the predominant reason why BP is high is stimulation of alpha-1 receptor. It causes vasoconstriction, BP increases. So we will tend to block alpha-1 receptor, so the BP should decrease. So if we give alpha blocker to a noradrenaline producing tumor, so it will block the extra vasoconstriction caused by alpha-1, and blood pressure will come back to normal around 120. So there is no problem. We can use alpha-1 blockers in noradrenaline producing tumor. But if we try to do same thing here, we try to give alpha-1 blocker in adrenaline producing tumor, what will happen? Yes, now the vasomotor reversal will occur and the blood pressure will not become 120, rather it will reach the 20 or 10. So person will develop severe hypotension and the person will die. Yeah? So this is the important thing, that if a person is having adrenaline producing pheochromocytoma, only alpha blocker is dangerous. So only alpha blocker should not be given to patient producing adrenaline primarily. Clear? Now question is, in which out of these two pheochromocytomas we can give only beta blocker? In none of them. Reason being, in this person the BP is 180, not 220, 230, because the endogenous adrenaline is stimulating beta 2, and that beta 2 is causing vasodilation, and that decreases the BP slightly. So if we block beta 2, so that extra vasodilation caused by beta 2 is stopped, and the blood pressure from 180 will become 220, and the person can develop cerebral hemorrhage. The blood vessels in the brain may rupture. So beta blocker alone, they are contraindicated in every patient of pheochromocytoma. Okay. So what we discussed so far is, alpha blocker alone is contraindicated in adrenaline producing tumor. Beta blocker alone is contraindicated in both adrenaline producing as well as noradrenaline producing tumor. So the question is then, how to manage the hypertension in adrenaline producing pheochromocytoma? We cannot give alpha blocker, we cannot give beta blocker. How we can manage is, we will give alpha plus beta blocker. Remember, vasomotor reversal of Dale was occurring because there was unopposed beta 2 action. When we block alpha-1, only beta 2 is stimulated, that cause vasodilation, BP decreases. So if we block that beta also, so vasomotor reversal will not occur. Or we can say we have reversed the reversal, re-reversal will occur. So alpha plus beta blocker should be given in adrenaline producing tumor. Okay? So if we summarize what we have discussed, we have adrenaline producing tumor, we have noradrenaline producing tumor. So three type of drugs: alpha blocker alone, beta blocker alone, and alpha plus beta blocker. So we discussed alpha blocker alone is contraindicated in adrenaline producing tumor. Otherwise, vasomotor reversal of tail can occur. On the other hand, alpha blocker alone can be used in noradrenaline producing tumor, no problem. But on the other hand, beta blocker alone are contraindicated in both type of tumors. Whereas alpha plus beta blocker, they can be given in both of them. And in fact, for adrenaline producing tumor, the only treatment is combination. So this is all about the catecholamine group of sympathomimetic drugs. So the last group of sympathomimetic drugs remaining are non-catecholam. Now non-catecholamines will discuss according to the receptors on which they are working. First is the drug stimulating alpha-1 receptors. First of all, we have a drug called as phenylephrine. Phenylephrine. It stimulates alpha-1 receptors and it is mainly used as eye drops. So what is the effect of alpha-1 receptor in the eye? Yes, it causes mydriasis. So phenylephrine is used for mydriasis. Now do you remember which other drug we discussed that cause mydriasis? Yes, anticholinergic drugs cause mydriasis. So what is the difference between anticholinergic drug and phenylephrine in the eye? The difference is anticholinergic drugs cause mydriasis as well as cycloplegia, whereas phenylephrine cause only mydriasis, no cycloplegia. So that is very important to remember. Anticholinergic drugs cause both cycloplegia and mydriasis, whereas phenylephrine cause only mydriasis, no cycloplegia. Now another drug which stimulate alpha-1 receptors, these include methoxamine, mephentermine, and midodrine. Methoxamine, mephentermine, and midodrine. These drugs are mainly used for effect on the blood vessels. And what is the effect of alpha-1 on the blood vessel? It causes vasoconstriction, so BP will increase. And in which condition we will like to increase BP? We will like to increase BP in hypotension or shock. So these drugs, they are used for treatment of shock or hypotension. Then we have third group of drugs which stimulate alpha-1 receptors. These include xylometazole, oxymetazole, and nefazole. These all drugs stimulate alpha-1 receptors and they are given as nasal drops. Obviously, they will be used for treatment of nasal congestion. So these drugs are used as nasal decongestants. They are used to open the blocked nose. So we have three types of drugs acting on alpha-1 receptors. The drug can be used as eye drops, which is phenylephrine. The drug can be used as nasal decongestant. These are metazoline derived drugs. And third, we can use a drug to produce vasoconstriction to treat the shock like methoxamine, mephentermine. So that is all important about the alpha-1 receptors. Now coming to drug stimulating alpha-2 receptors. The drug stimulating alpha-2 receptors are clonidine and methyl-dopa. Clonidine and methyl-dopa. And we discussed the function of alpha-2 receptor was. It was acting like a brake. That means it was stopping the sympathetic activity. So when we give clonidine or methyl-dopa, they will stop sympathetic activity. So what will happen to blood pressure? The blood pressure will decrease. So these drugs, they are used to decrease blood pressure. That means used for treatment of hypertension. So clonidine and methyl-dopa, they are used for treatment of hypertension. Then lastly, we have drug stimulating beta-2 receptors. Remember, we do not have a non-catecholamine which acts on beta-1 receptors. So on beta-1 receptors, mainly we have catecholamines like dopamine, dobutamine like drugs. Now drug stimulating beta-2 receptors, the examples are salbutamol, terbutalin, salmeterol, and formoterol. They stimulate beta-2 receptors, and stimulation of beta-2 receptors result in bronchodilation. So these are given by inhalational route and they are used in treatment of bronchial asthma. Inhalational route, they are used in treatment of bronchial asthma. Now, more details about these will cover in respiratory system. We have another drug which stimulates beta-2 receptors. These are ritodrine and isoxsuprine. They also stimulate beta-2 receptors, but they are mainly used for their action on the uterus. Mainly used for their action on the uterus. So what is the effect of stimulating beta-2 on uterus? Yes, it relaxes the uterus. So these drugs are used as tocolytic drugs for treatment of preterm labor. So they used to delay the labor pains used for preterm labor. The next group of non-catecholamine can be beta-3 agonist, and the drug which stimulates beta-3 receptor is mirabegron. Beta-3 is primarily present on the adipose tissue and on the urinary bladder. Okay? So mainly on the urinary bladder, the drug is working. So beta-3 relaxes the bladder. So the drug which stimulates beta-3 will relax the bladder, so it can be used in overactive bladder. So mirabegron is used for overactive bladder. It relaxes the bladder and it will
secrete the overactive bladder. And from the name you can remember, in Hindi if you study, the name look like Mera bladder gone, Mera background, Mera bladder gone. So bladder has relaxed. So that is beta 3 agonist. Clear?